Yeah, a very warm welcome to all. So let's begin our session of IPL INI-CET Premier League T20, and we continue the series for dermatology today. Hi, hi Bhavesh, hi Prakhar, Dilyang, hi. Thank you for joining in, Sunil. So we will be beginning with our session for today. We'll be discussing multiple varied topics today. I would request you to be more and more interactive. Okay. Before I start, I want you to know that an academy has come up with a very good offer, which I think everybody should utilize. It is a flat 25% off on the NEET PG Vitals, that is the recorded lectures. Okay, they are free along with the physical notes on 6 months and above subscriptions for INI-CET and FMGE. So there is a flat 25% off on these subscriptions, and you can also get a free extension up to 12 months. You can see what is the pricing currently. So for 24 months, what you pay is 25,000. What you pay for 12 months plus 3 months is 17,531. What you pay for 9 months plus 2 months is 15,938. So this particular offer is valid only till April 30. Okay, so I would request all of you to please do utilize this offer, and whenever you do, please use the code mentor, MENTOR is the code to get this offer, to avail this offer. Okay, so remember, there is a flat 25% subscription off on all NEXT, INI-CET and FMGE examinations. These are the stars of an academy who have done very well in their NEET PG 2023 examinations. As you can see, rank 3, rank 16, all of them have been through an academy. Also, to notify you, there is a last mile FMGE preparation batch which is going on the Unacademy store. So this particular subscription is for 3 months, which has more than 200 hours of lectures. Currently you can get the subscription, which was actually 7,500, for only 2,062. Okay, and for this you need to use the code mentor. Okay, MENTOR as the code which you can use to get access to this subscription. Also, please remember that there is NEXT NEET PG focused kind of a subscription which is for 9 months. It's a live subscription, okay, which is for 15,938. The advantages of a live subscription is that you will be attending live classes, so you can get your live doubts cleared in real time. Okay, and in addition to this, you will also have free vitals and 2 months extension. So for this also, you please use the code mentor, MENTOR. Mentor is the code that you need to use. Okay, now let's begin with our session for today. Now, I hope you can see the first MCQ. Please see the image that's provided. Okay, now a 25-year-old female comes with paronychia. You can see the image. She comes with paronychia on the middle finger and has the given finding. What is the suitable antibiotic in this case? Will it be amoxiclav? Will it be amikacin, norfloxacin, or metronidazole? The MCQs that I'll be discussing in this session are the MCQs which have been asked in the previous NEET and the INI-CET examinations. Okay. So, Shubham says C, Navneet, Jia, Pushpa, Shahu, Adnan, all are of the opinion that it is A, and that is the correct answer. It is amoxicillin clavulanic acid combination. Very good, all of you. Very good, Kishore, Dr. Mehta. That's very great. So this particular problem that we can see is a case of acute paronychia. Why is it acute paronychia? You can appreciate the amount of inflammation that is there. You can appreciate the redness, you can appreciate the swelling, as well as you can see in this area there is an actual pus pointing. So acute paronychia, it's a very painful condition, okay, and it is acute in onset, versus chronic paronychia, which is a chronic condition, and the patient has swelling and redness which is much more pronounced in acute paronychia. Pustulation is much more pronounced in acute paronychia. The cause of acute paronychia is infection. It's a bacterial infection, right? And most commonly it is because of staphylococci and streptococci, and hence the most appropriate antibiotic in this case will be amoxicillin clavulanic acid. Versus chronic paronychia, it's mainly because of the cuticle. You know what's the cuticle, right? The cuticle is a very fine, delicate layer which seals the space in between the proximal nail fold and the nail plate. So if because of some reason, either because of repeated hand washing, or because of uncontrolled diabetes, or because of repeated exposure to detergents, or because of an inappropriate manicure, if this particular cuticle gets damaged, there is a space which is created between the proximal nail fold and the nail plate. Now this space, through this space there will be water going in, there will be food going in, there will be certain chemicals going in, so that can cause a kind of an irritant dermatitis, okay, over the proximal nail fold. Also that particular space is a very cozy, comfortable space for the bacteria to grow as well as for the fungi to grow, and that gives rise to itching, burning sensation, pain occasionally, but the pain is definitely not as severe as in acute paronychia, and that leads to persistent swelling and redness over the proximal nail fold. Eventually, when this infection involves the matrix, it causes dystrophic changes of the nail plate as well. So what you need to understand is acute paronychia is bacterial. You have to treat it with antibiotics. Chronic paronychia, it is fungal in nature, okay. It's not just the fungal infection, there is superadded bacterial, there is superadded contact dermatitis, but primarily if you have to treat it, you will treat it like you treat a fungal infection with irritant dermatitis, okay. Now let's go on to the next question. You have a male patient who presents with the complaints of urethral discharge, okay. Identify the causative agent. So what can you see? You can see that there is thick purulent discharge which is per urethra. You can tell me what is the causative organism. Please write it in the chat box. Yeah, so Smriti, Shubham, Adnan, Pushpa, Shahu, Jia, Shubham, Kishore, Viraj, Navneet, Thor and Prakhar. All of you are right. Yes, this is nothing but gonorrhea, which is caused by Neisseria gonorrhoeae. Okay, Neisseria gonorrhoeae, it causes acute urethritis. Basically, it causes thick mucopurulent discharge. Yes, as Shubham very rightly said, gonorrhea literally means seed of pus, okay. So gonorrhea means actually a seed of pus, and you can appreciate here that very well in this picture, right. So gonococcal urethritis is caused by Neisseria gonorrhoeae, and it is the second most common sexually transmitted infection in the world. The incubation period is very short. It will be between 2 to 8 days. The classical manifestation is thick, purulent urethral discharge. Others have prostatitis, epididymo, orchitis, but testis is usually not involved. In females, what happens is that, please remember that gonorrhea is not going to cause vaginitis. It is going to cause cervicitis. Okay. So remember, it involves the endocervix. So primary infection of gonorrhea is in the endocervix, and from the cervix it then, because it is asymptomatic, when it involves the cervix, the patient is asymptomatic, and you know that the reproductive system in the female, it communicates directly with the peritoneum, right, and it through the fallopian tubes, right? So there is always a chance of any infection, if it goes asymptomatic, if it goes untreated, there is a very high chance that it is going to disseminate, right? So primary infection is in the endocervix. It is often asymptomatic but can cause cervical discharge, salpingitis, and it can go into pelvic inflammatory disease. Okay, you must have heard the term perihepatitis. Okay, perihepatitis is a complication of it's a complication of gonorrhea, disseminated gonococcal infection, and this is more commonly seen in chlamydial infections more than gonorrhea, but at times can be seen in gonorrhea as well. So perihepatitis is characterized by the violin string strands which attach from the liver capsule and then go on to the peritoneum. Okay, so this is something more commonly seen though in chlamydial infection, which is also, as Adnan correctly mentions, it is also called as the Fitzhugh-Curtis syndrome. Correct? Yes, very good, Shubham. Right, so how do you diagnose gonorrhea? What you can easily do is to take a smear. You can take a smear from the urethral discharge, and you can subject it to a gram stain. On gram stain, you will see the presence of gram-negative diplococci, and you can also culture. Okay, culture is definitely the gold standard for the diagnosis of gonorrhea. You can also perform a nucleic acid amplification test on urine, urethral discharge, cervix, or the vagina. How do you treat gonococcal infection? You have to treat it with injection ceftriaxone 250 mg given intramuscularly, single dose, or you can give him tablet cefixime 400 mg, single dose. And always remember that whenever you are going to treat any kind of urethral discharge, please also add on tablet azithromycin 1 gram stat, because most of the times what happens is that the gonococcal infection is going to coexist with the chlamydial infection. If you just treat the gonococcal infection with ceftriaxone or cefixime, the chlamydial infection will persist, and that will give rise to something called as post-gonococcal urethritis, where the symptoms are going to persist even after appropriate treatment of gonorrhea. Hence, please remember, always add on tablet azithromycin 1 gram stat, that is for the non-gonococcal urethritis. Okay, now non-gonococcal urethritis is caused by chlamydia. It is the most common cause of non-gonococcal urethritis. The other organisms which cause non-gonococcal urethritis include ureaplasmia, urealyticum, mycoplasma genitalium, and rarely trichomonas. Okay, now non-gonococcal urethritis is the most common bacterial STI in the world. The incubation period is 1 to 3 weeks. Now, what is the difference between the discharge of gonorrhea and non-gonococcal urethritis? In gonorrhea, the discharge is thick, it is purulent, while in non-gonococcal urethritis, the discharge is watery, thin, and it is mucopurulent. It can complicate to cause epididymitis and pelvic inflammatory disease. How do you diagnose NGU? By doing a nucleic acid amplification test, and that is the only recommended test. So remember, whenever you are suspecting non-gonococcal urethritis, take a urethral swab and subject it to nucleic acid amplification test, and treatment of this particular condition is with azithromycin, right? So S correctly mentions that you need to use a grey kit for urethral discharge. Can you tell me which kit is the color? Which color is the kit for vaginal discharge? What is the color of the kit for vaginal discharge? Yes, very good, Shubham. It's green. Yes, very good. Very good. It is green. What is the color of the kit for treating genital ulcerative disease, which is associated with vesicles? What is the color of the kit for genital ulcerative disease which is associated with preceding vesicles? Red. Yes, very good. Red kit is used to treat herpes genitalis, where the content is acyclovir, right? Yes. All correct. Can you tell me what is the color of the kit which is used for treating bubo or inguinal swelling? Bubo or inguinal swelling. What is the color of the kit? Very good. Yes, Shubham, Shilpi, Viraj, all of you are right. Yes, the answer is black kit. Yes. Now, somebody asked me, yeah, how to differentiate between neonatal pemphigus and epidermolysis bullosa on the basis of history and clinical features. So, basically, see, what is neonatal pemphigus? Neonatal pemphigus is when the mother is having pemphigus and the mother transmits the antibodies against the desmoglein 1 and 3 transplacentally to the baby, and that's how the baby gets neonatal pemphigus. Okay, so in neonatal pemphigus the patient is going to develop blisters. They will be flaccid blisters over normal appearing skin, and they are going to be for a transient duration. That is because once those antibodies are out of the system, the pemphigus itself is going to settle, because the body of the baby by itself is not producing the antibodies. The antibodies are passively transferred from the mother to the baby, right? So neonatal pemphigus is characterized by the presence of bullae, which will be flaccid and they will be self-limiting, and most of the times you do not need to treat very aggressively, just give topical applications for the bullae and erosions. While epidermolysis bullosa, it is a mechanobullous disorder. Now you know that there are various types of epidermolysis bullosa like simplex, junctionalis, epidermolysis bullosa dystrophica. So why does epidermolysis bullosa occur? It occurs because of a genetic defect in certain components of the dermoepidermal junction. Like for example, in epidermolysis bullosa simplex, there is a congenital absence of keratin 5 and 14. In epidermolysis bullosa junctionalis, there is a congenital absence of laminin 5. And in epidermolysis bullosa dystrophica, there is a congenital absence of collagen 7. So when you have congenital absence of certain components of the dermoepidermal junction, whenever there is friction, wherever there is trauma, the patient is going to develop blisters. So in both these situations, in neonatal pemphigus as well as in epidermolysis bullosa, there are going to be blisters which may be present at birth. But the location of the blisters in epidermolysis bullosa will be on the trauma prone areas, and these blisters are going to they are going to persist. Like, it's not something self-limiting. Neonatal pemphigus will have oral lesions as well. Okay, in epidermolysis bullosa junctionalis dystrophica, there can be oral lesions as well, but they not be present as early as birth. They may develop a few days later once the child starts suckling, or when the child starts feeding, right? So basically that is the primary difference, that in epidermolysis bullosa the blisters are going to happen at the site of friction and trauma. Okay, and while neonatal pemphigus is self-limiting, epidermolysis bullosa is going to continue. It is not going to be self-limiting. Okay, now Shubham says in epidermolysis bullosa dapsone will be needed for treatment. See, Shubham, you are confusing yourself here. There are two entities. One is epidermolysis bullosa dystrophica, and next is epidermolysis bullosa acquisita. These are two very, very different entities. When you are talking about epidermolysis bullosa dystrophica, it happens because of the congenital absence of the collagen 7. While epidermolysis bullosa acquisita is because of antibodies which are targeting the collagen 7. Right? So they are two different things. One is a congenital problem, another is an acquired problem. For treatment of epidermolysis bullosa acquisita, you can use dapsone. Okay, you can, of course, you can use steroids, but you can use dapsone as well, right? While in epidermolysis bullosa dystrophica, or for that matter any other epidermolysis bullosa, whether it is simplex or junctionalis, dapsone is not going to help, and nor any immunosuppressive is going to help, because it is a structural defect in the skin. I hope that's clear. Can we move ahead? Yes, welcome Shubham and S. So now let's go to the next question. You have a 30-year-old who has come with flaccid bullae. Okay, the patient has come with flaccid bullae on her skin which are easy to rupture. Biopsy reveals a suprabasal split. Identify the diagnosis. Okay, I am seeing a lot of varied response here. Some have answered A, some have answered B, some have answered D. Look at the question properly. They are flaccid bullae and there is a suprabasal split. Yes, yes. So the correct answer here is pemphigus vulgaris. Yes, yes, Shubham, you are right. So basically it is pemphigus vulgaris. Pemphigus vulgaris is a condition in which you have antibodies which are of the IgG type, and these antibodies are directed against desmoglein 1 and desmoglein 3. Now if you understand, the location of desmoglein 1 is in the subcorneal location and desmoglein 3 is in the suprabasal location. Okay, so that is why in pemphigus vulgaris you have a suprabasal split, and as Adnan very rightly said, it is a suprabasal split, and inside that split, inside that water which is accumulated in the split, what will you see? You will see there will be some acantholytic cells, and you will also see that the basal layer is firmly attached to the underlying dermoepidermal junction and it projects into the cleft, and that looks like a row of tombstones appearance. Correct? So that is called as row of tombstone appearance. So primarily just look at this picture. This is the structure of the epidermis. So see here in this, somewhere here is your desmoglein 1. Okay, and somewhere here is your desmoglein 3. Right? So when you have antibodies against desmoglein 1, you will have a subcorneal split which you see in pemphigus foliaceus, while in pemphigus vulgaris you will have a suprabasal split. Okay, that means it is just above the basal layer. So primarily what happens in pemphigus group of disorders is that there are these antibodies which are directed against the desmogleins. The desmogleins are structures which are involved in formation of the desmosome. Right? What is the desmosome? The desmosome is something that helps to keep two keratinocytes together. Now when there is anti-desmosomal antibody or anti-desmoglein antibody formed, what will happen is that the cells will not remain attached to each other, and when the cells cannot remain attached to each other, they will assume the shape of least surface tension, which is a circular shape. And what will happen is the nucleus will turn larger and there will be peripheral condensation of cytoplasm which will give rise to a perinuclear halo. So this cell, which was polygonal, because it lost its attachment, there will be conversion into an acantholytic cell. Acantholytic cell is also called as the Zank cell. Right? So this is your Zank cell. So what do you see? You see that there are multiple acantholytic cells, and in between the acantholytic cells you get accumulation of fluid. So this is what the acantholytic cell looks like on a smear, on a Zank smear. Okay, so you need to remember this image very well because this can come to you as an image based MCQ. You can appreciate here, this is a very classical Zank cell. It's a large cell which is rounded, and you can see that there is a large nucleus and there is peripheral perinuclear halo. Right? Yes, very good Shahu, very good Mehta. Yeah, all of you are right. These are Zank cells. See, this is also a Zank cell. Here also you see there is a Zank cell. Okay, all these are Zank cells. So this is the acantholytic cells which are seen on a Zank smear of a patient with pemphigus. Now this is again a very important slide which is showing you the histopathology of pemphigus vulgaris and pemphigus foliaceus. So what is this? This is your stratum corneum. Okay. Then you have, this is your stratum granulosum. Correct? The dark blue color is the stratum granulosum. This is your stratum spinosum. And what do you see? This is your stratum basal. So in between the basal cell layer, and the stratum spinosum, you can see there is this cleft. Okay, so there is a suprabasal cleft. So this is nothing but pemphigus vulgaris. Now you compare this with pemphigus foliaceus. What do you see? This is the stratum corneum. Immediately below the stratum corneum you see a cleft. Okay, so this is the subcorneal cleft which you are going to expect in pemphigus foliaceus. Okay, now very important, please remember what are the differences in between pemphigus vulgaris and pemphigus foliaceus. In pemphigus vulgaris you will see flaccid bullae, right? They are going to be flaccid bullae because they are intraepidermal bullae. So they are flaccid bullae which are easily rupturable. Okay, you can easily rupture them because the roof of the bulla is quite fragile. No, it is just made up of the stratum corneum, granulosum and the spinosum, right? And there will be mucosal erosions. Now mucosal erosions will be present only in pemphigus vulgaris. They are not going to be present in pemphigus foliaceus. The reason is that anti-desmoglein 3 antibodies are present in pemphigus vulgaris, and desmoglein 3 is present in the oral cavity, while desmoglein 1 and 3 are present in the skin, but in the mucosa you only get desmoglein 3, you do not have desmoglein 1. That is why in pemphigus vulgaris you will have mucosal erosion. So read the question carefully. If they tell you that the oral mucosa is involved, it has to be pemphigus vulgaris. Okay, it cannot be pemphigus foliaceus like in this question. Okay, now in pemphigus foliaceus what happens is, one is that the oral cavity involvement or mucosal involvement is absent. The second thing is, if you see in pemphigus foliaceus, the roof of the blister is extremely fragile. It is formed only of the stratum corneum, right? So it is very impossible most of the times that you are going to see an intact bulla. Most of the times in pemphigus foliaceus what you end up seeing is just erosions and crusted lesions, right? So please remember, why is pemphigus foliaceus called so? Because the foliaceus comes from the word foliage. What is the meaning of foliage? Foliage means leaves. And how does leaves comes here? Because leaf-like scales are seen in pemphigus foliaceus. Why do we see scales and crusts in pemphigus foliaceus? Because the roof of the pemphigus foliaceus blister is very fragile, so it's unlikely you will see an intact bulla. You will most of the times see only erosions, crusted lesions and scaly lesions, right? So what you need to remember about pemphigus vulgaris is that the first site of involvement is the mouth. The mean age of presentation is around 40 years. The Nikolsky sign is positive. What is Nikolsky sign? When you apply lateral pressure or shearing force onto normal looking skin surrounding a blister or an erosion of pemphigus, you will see, initially you will feel that the epidermis is moving over the underlying dermis and then the epidermis peels out. Okay, so that is called as Nikolsky sign. So Nikolsky sign is something that you will see positive in intraepidermal blistering disorders. Okay, so which are the intraepidermal blistering disorders which will show you the Nikolsky sign positive? You will see Nikolsky sign positive in all pemphigus as well as its variants. Okay, then you will also see it positive in staphylococcal scarlet skin syndrome. You will also see it positive in Haley disease. Okay, and the pseudo Nikolsky positivity is what you appreciate in toxic epidermal necrolysis. Okay, so please remember the causes of a positive Nikolsky sign. All of these are intraepidermal blistering disorders. Okay, so what is SSSS? SSSS is staphylococcal scarlet skin syndrome. It's a condition which is caused by staphylococcal infection. This staphylococcal infection may be occult or it may be manifest, and this Staphylococcus phage type 2 releases a toxin which is called as the epidermolytic toxin. This epidermolytic toxin cleaves the desmoglein 1, which leads to subcorneal bullae, and the Nikolsky is positive. In Haley disease, it is a problem. It's an inheritable condition where you have a problem of the calcium pump. Okay, there is a mutation in the ATP2C1 gene, as a result of which there is a problem with the calcium pump. Now the calcium pump is responsible for pushing the calcium from the extracellular location into the intracellular location. Okay, so when you do not have a proper calcium pump functional, what happens is your desmosome cannot function. When your desmosome cannot function, what's going to happen is that the cells will not be able to stay with each other. They will not be able to remain attached to each other, and that will give rise to acantholysis, right? So in Hailey-Hailey disease also you have your Nikolsky sign positive. In toxic epidermal necrolysis, what happens is that there is epidermal necrosis, there is apoptosis of the keratinocytes, as a result of which the epidermis is separated from the dermis. It undergoes necrosis. So there is a Nikolsky sign positive, right? So please remember these causes. Now let's go on to the next question. You have a patient who is on multibacillary multi-drug therapy, okay, and presented with inflammation over pre-existing lesions, and there is nerve involvement. What is your next line of management? Will you stop MB-MDT and start steroids? Will you stop MB-MDT and give thalidomide? Will you continue MB-MDT and steroids, or will you continue MB-MDT and give thalidomide? Right. So, Shubham, Smriti, Pushpa, Shruti. Yeah, all of you are right. Very, very good. The correct answer here is you continue multi-drug therapy and give steroids. So, the problem that you are dealing with, as Shubham and Shahu correctly mentioned, it is a type 1 lepra reaction. So, what is a lepra reaction? You know that leprosy by itself is a very chronic condition, right? So, when you have an acute event occurring in the otherwise chronic course of leprosy, then you call it as a lepra reaction. Okay. Now, what is type 1 lepra reaction? What is type 2 lepra reaction? Yes, Shubham rightly mentions that type 1 lepra reaction is a type 4 hypersensitivity reaction, and type 2 lepra reaction, it's a type 3 hypersensitivity reaction. Okay, what happens in type 1 lepra reaction is the existing lesions of Hansen's disease, they tend to become erythematous, they tend to become inflamed, they tend to become tender, they tend to become swollen. Okay, while in type 2 lepra reaction, the existing lesions of Hansen's will remain the way they are not going to change, but there will be appearance of newer eruptions which are called as erythema nodosum leprosum. Okay, so what are erythema nodosum leprosum? Erythema nodosum leprosum, they are erythematous subcutaneous nodules which are going to come onto the proximal extremities and the trunk, and they are going to gradually resolve on their own, and then a new crop is going to come, right? So this is something that occurs in crops, and when they disappear, they heal with hyperpigmentation. Okay, so that is what happens in type 2 lepra reaction. Now here they have mentioned that there is nerve involvement. Please remember, nerve involvement is very much severe in a type 1 lepra reaction versus a type 2 lepra reaction. The nerve involvement in type 1 lepra reaction can be severe enough to cause extreme neuritis and nerve abscess formation. And when you have a nerve abscess, you will have to do a incision and drainage. Of course, start the patient on steroids, but also do an incision and drainage. Okay, so remember that type 1 reaction will show a severe nerve involvement versus type 2 lepra reaction will show a involvement of the nerves, but it will not be as severe as a type 1 lepra reaction. Another point of difference which you need to remember is that systemic symptoms, they are going to be much more severe in a type 2 lepra reaction versus a type 1 lepra reaction. In type 2 lepra reaction, you can have systemic involvement in the form of uveitis, hepatitis, gastritis, glomerulonephritis, orchitis, right? So systemic involvement is much more severe in a type 2 lepra reaction versus a type 1 lepra reaction. Now, how do you treat type 1 lepra reaction? It is via giving steroids. Okay, if it is a mild type 1 lepra reaction, you can give aspirin. Okay, but the main treatment is with steroids. And what is the treatment for a type 2 lepra reaction? The treatment of type 2 lepra reaction is also a steroid, but type 2 lepra reactions can be recurrent. Type 2 lepra reactions can become steroid dependent. Like type 2 reactions can be steroid recalcitrant. So in such situations, when you have a patient who you cannot give steroids, you have a patient who is steroid dependent, in a patient who has already developed all the side effects of steroids and you don't want to give steroids, in that case the drug of choice will be thalidomide. Thalidomide is the most rapidly acting drug for type 2 lepra reaction, but the problem with thalidomide is that it is teratogenic. So if there is any chance that there is a pregnancy, definitely you should not be giving thalidomide. Another drug which you can give in addition to steroid is clofazimine. It is used in a higher dose. See, the regular MDT dose of clofazimine is 50 milligrams daily, right? But when you have to give it for a reaction, you have to give it in a much higher dose, which is up to 300 milligrams a day. Okay? So this is all that I have already told you. Now let's go on to the next question. Look at the image that's provided to you. You have a patient who has come to you with a rash. What additional history will you ask? Will you ask history of diarrhea or memory impairment, diarrhea and food intake, memory impairment and food intake, or diarrhea and arthritis? Right, so I see, yes, all of you are right. The correct answer here is A, which is pellagra. So pellagra, why is this pellagra? Because the picture shows you the typical castle's necklace, right? Castle's necklace. And because as Shubham correctly mentions, pellagra is characterized by diarrhea, dermatitis, dementia and death, right? So the correct answer here is A. Now, next question. You have a 6-year-old girl who is presenting with rough surface lesions over her elbows, knees, and also has problems with night vision. What is your diagnosis? Yes, you are right. All of you are right. The correct answer here is phrinoderma. Okay, so phrinoderma is the correct answer. Now let's go to the next question. You have a male child with mild painful swelling on the scalp for 3 months. The patient has a dog pet at house. So Smriti, Akila, Navneet, Mehta, Shruti, Sunil, Shubham. Yes, very good. Very good. The correct answer here is carrion. So what do you see? There is an inflammatory boggy swelling which is studded with pustules on the scalp of a child, and this child also has a dog in the house. So that is suggesting that there is more of a zoonotic species which has caused this carrion, right? So carrion is characterized by this swelling. Okay, please remember, painful boggy swelling on the scalp which is studded with pustules is what is seen in carrion, and especially this will be in the pediatric age group. Why in the pediatric age group? Because in the pediatric age group sebum is absent. Sebum is under the influence of androgens, right? So unless they achieve puberty, they are not going to have too much sebum on their scalp. So this sebum is supposed to be fungistatic. So that is why tinea capitis is much more common in children versus in adults. Now remember the organisms which cause carrion. Remember the mnemonic: men can be very red. Red stands for inflammation. Okay, so men stands for mentagrophytes, can stands for canis, and veri stands for verrucosum. Okay, so remember, men can be very red, mentagrophytes, which was possibly the organism in this case, verrucosum, canis, and this can be an ectothrix infection. Ectothrix means the fungal organisms are situated outside the hair shaft, and therefore you will get the Woods lamp positive, or it could be an endothrix infection where the fungal organisms and the spores are situated inside the hair shaft and the Woods lamp is expected to be negative. So this is the classical picture. So you see here there is a boggy indurated swelling on the scalp which is studded with pustules. So okay, see S what you are talking about is the non-inflammatory variant of tinea capitis, that is the grey patch and the black dot variant of tinea capitis. Now carrion is an inflammatory variant of tinea capitis. The black dot variant of tinea capitis is caused by the endothrix organisms like Trichophyton verrucosum and Trichophyton tonsurans. Okay, so remember, black dot variant of tinea capitis is a non-inflammatory variant of tinea capitis, while grey patch is also a non-inflammatory variant of tinea capitis, but it is ectothrix infection. So here you will see that the organisms are located outside the hair shaft, right? So the organisms which cause ectothrix infections include Canis, Oduni, Ferruginum. Okay, Microsporum, Canis, Oduni and Ferruginum, they cause grey patch variant of tinea capitis. So grey patch and black dot are included under the non-inflammatory variants of tinea capitis. So when you treat them, you will expect a full growth of hair. While in carrion, because it's an inflammatory variant of tinea capitis, there is likelihood of cicatrization. So when it heals, it may heal with cicatricial alopecia, scarring alopecia, and there may not be complete regrowth of the hair. So the earlier you identify, earlier you treat a carrion, the better it is. Because it's an inflammatory variant, you will also see associated lymphadenopathy. Now, donovenosis is caused by yes, so all of you are right. The correct answer here is Klebsiella granulomatis. Okay, H. ducrei, it is causing chancroid. H. ducrei causes chancroid. Leishmania donovani causes leishmaniasis. Treponema pallidum causes syphilis. Okay, and donovanosis is caused by Klebsiella granulomatis. Also it is called as Calimatobacterium granulomatis. So donovanosis is a sexually transmitted condition which is caused by Klebsiella granulomatis. So this is what it looks like. See, granuloma and inguinale is the other name for donovanosis. Now, what is the clinical characteristic? It's a chronic granulomatous locally destructive ulceration which is caused by Calimatobacterium granulomatis. It is characterized by the presence of painless ulcers. Please remember, this is a cause of painless ulcer. It is a foul smelling ulcer, and on the base of the ulcer you will see exuberant vascular granulation tissue on the floor, which gives rise to a beefy red appearance, and it bleeds easily on touch. Okay, so this is something that you need to remember. It's a chronic locally destructive ulceration which is caused by Calimatobacterium granulomatis. It's a painless ulcer. Remember, painless ulcer, and there is a lot of granulation tissue at the base, and that gives rise to a beefy red appearance, and it bleeds on touch. Very good, Shubham. It is characterized by the presence of lymph nodes which are absent, and instead of the lymph node swelling, there is a granulomatous swelling at the site of the lymph node, and that is why it is called as the pseudobubo. So remember, pseudobubo is what is seen in donovenosis, pseudodono. Okay, so pseudovenosis, the donovenosis shows pseudobubo. Okay, so regional lymph nodes are not enlarged and you have granulomatous swellings occurring in the inguinal area. Since no lymphadenopathy occurs, it is called as pseudobubo. Squamous cell carcinoma is a late complication because it's a chronic ulceration. So how will you diagnose it? What you can do is, there is a lot of beefy granulation tissue on the floor. So you just have to take a pinch of the granulation tissue, or you biopsy that granulation tissue and you take the material in between the slides. Crush it in between the two slides, and then you stain it with Wright's or Giemsa stain, and that will show you the presence of parasitized histiocytes which are containing Donovan bodies. Okay, so this is what it looks like. This is a histiocyte within which you can see the Donovan bodies, which are nothing but showing you a closed safety pin appearance, right? There is a closed safety pin appearance. So how do you treat donovenosis? You give azithromycin 1 gram orally per week. You can give doxy, you can give ciprofloxacin, you can give Septran as well. Now, next question. Fungal infection which is acquired by traumatic inoculation is Sporothrix schenki, blastomycosis, coccidiosis or paracoccidiosis. Great. So all of you have answered correctly. It is basically caused because of Sporothrix schenki, right? So Sporothrix schenki, it's a thermally dimorphic fungus, correct, that lives on vegetation. So it is associated with a lot of plants, grasses, trees, moss, bushes and horticultural plants. So the conidial or the hyphal elements of Sporothrix schenki, they are introduced into the skin via trauma. So it is via inoculation. Following a traumatic inoculation into the skin, Sporothrix schenki causes porotrichosis, which is a chronic granulomatous infection. Okay, so remember, yes, you can, yes, it is also called as Rose Handler's disease, also called as Rose Gardner's disease. It is a subcutaneous fungal infection, yes Shubham, and typically it causes a lymphatic spread. Yes, you are very right. The lymphatic type of sporotrichosis is the most common variant, where you see a linear chain of ulcerating nodules and sinuses along the lymphatics. On histopathology, you will see small cigar-shaped or oval yeast cells which are surrounded by a eosinophilic substance, like you can see in this picture. Okay, and these are called as asteroid bodies. Yes, very good, they are asteroid bodies. So remember that something that resembles porotrichosis occurring in a lymphatic distribution, linear distribution, is fish tank granuloma. Fish tank granuloma is a typical mycobacterial infection which is caused by Mycobacterium marinum. This is commonly something that you see in fish handlers or swimmers. It resembles sporotrichosis. So this is what sporotrichosis looks like, linear pattern of ulcerating nodulo-ulcerative lesions. Now, let's go to the next question. You have a child who is born with a thick membranous coat. What could be the possible diagnosis? Lamellar ichthyosis, X-linked ichthyosis, ichthyosis vulgaris or acquired ichthyosis? Right, so all of you are right. Basically what they are talking about is that the patient is coming to you with a colloidal membrane. So what is this colloidal membrane? It is a parchment like membrane. It's a kind of a plastic like thick membranous coat which is encasing the entire body. Okay, and it is kind of making the child difficult to close the eyes because of its tautness, as a result of which the patient develops ectropion. The patient also has difficulty in closing the mouth completely because of eclabium. there is depressed bridge of because of that taut membrane. Okay, so it's a parchment like membrane which is covering the entire skin, right? So that is called as the colloidal membrane. This colloidal membrane is going to disintegrate, and then most of the times you start seeing the underlying ichthyosis coming up. So out of all the options that are provided, lamellar ichthyosis is the one which can present with colloidal membrane at birth. Okay, X-linked ichthyosis is going to present less than 3 months after birth, but it is not going to have a colloidal membrane. Ichthyosis vulgaris presents after 3 months of birth, does not have a colloidal membrane. And ichthyosis acquisita is something that is acquired ichthyosis, so obviously it is not associated with any manifestation at birth. Okay, Harlequin baby, science and spirituality. Harlequin baby, it is a very severe variant, okay, where you have thick plate like scales. It's like a coat of armor which is surrounding that entire skin, and these patients, they do have a very poor prognosis. They have severe ectropion, severe eclabium, there is difficulty in even feeding the child, right? So they have a poor prognosis. But colloidal baby is a milder form where you have the entire body covered in a thick membranous coat. It is going to disintegrate. Many a times it may be self-healing, and the skin may become completely normal, but in many conditions you will see that later on it presents with ichthyosis. Yes, you are right, fish-like scales. Okay, fish, not fishnet, fish-like scales are seen in ichthyosis vulgaris. So remember that in ichthyosis vulgaris, you will not see the appearance of lesions at birth. The skin is going to be completely okay at birth. A few months after birth, you will start seeing that the patient develops extreme dryness and develops fish-like scales which are more prominent on the extensors. The flexures are usually spared. The palms and soles are going to show you the presence of hyperlinearity, and you will also see that the patient becomes atopic, also has a tendency for developing keratosis pilaris. So remember, in ichthyosis vulgaris, the clinical presentation is not at birth, it develops a little late, and there is more of extensor involvement than flexural involvement. X-linked and ichthyosis vulgaris is an autosomal dominant condition. Okay, while X-linked ichthyosis is an X-linked condition where the presentation occurs below 3 months of age. Here you will see that the patient has more of flexural involvement, the extensors are spared, palms and soles are spared, and there can be associated involvement like cryptorchidism, and there can be ocular abnormalities as well. Okay, so X-linked ichthyosis, that is how it differs from ichthyosis vulgaris. So this is what the fish-like scales of ichthyosis vulgaris looks like. Okay, fish-like scales of ichthyosis vulgaris. This is X-linked ichthyosis, where you can see there is involvement more of the folds, more of the flexures. They also have a dirty neck. Okay, and they are fine, large, dirty brown looking scales, and this happens, X-linked ichthyosis happens because of deficiency of steroid sulfatase enzyme. Extensors are spared, flexures are involved, and there can be associated abnormalities like undescended testis and corneal opacities. This is the colloidal membrane which I was talking to you about, a thin parchment like membrane, thick membranous coat which is surrounding the entire body. This is eclabium, this is eclabium, this is ectropion. Here you can see that the child is not able to open the hand completely. So this is lamellar ichthyosis. This is what eventually the baby can go into, that is lamellar ichthyosis. Here you can see large plate like scales. Okay, so very large plate like scales looking like an armor are seen. Palms, soles, flexures, everything is involved in lamellar ichthyosis. Then going on to bullous ichthyosiform erythroderma. This presents at birth, but there is no colloidal baby, and presents with bullae, and they leave behind rough scales. Palm, soles, extensor flexures, all are involved, and in fact it presents with erythroderma. So now we have the last 5 minutes remaining. Are there any questions, any specific topics that you want me to discuss? Then you please let me know. Anything that you want me to specifically answer? Any questions? If no questions, then we discuss this MCQ. A female 26-year-old comes with oral ulcers, comes with photosensitivity and malar rash on the face, which is sparing the nasolabial folds on both the sides. What is your diagnosis? Is it Sturge-Weber syndrome, SLE, dermatitis or psoriasis? Yes, all of you are right. The correct answer here is systemic lupus erythematosus, and what you are dealing with is with the malar rash of SLE. The reason why it is malar rash of SLE is because it is sparing the nasolabial fold and the patient is also having oral ulcers with photosensitivity. Hence, these are the major criteria for diagnosis, and hence it is systemic lupus erythematosus. In Sturge-Weber syndrome, you are going to see the presence of a port wine stain on the face. Okay. In dermatitis, you are going to see more of an eczematous lesion. In psoriasis, you are going to see silvery micaceous scales over an erythematous plaque. Right? Now, science and spirituality tells me to discuss patch test. So, the last 4 minutes we will devote to patch test. So, remember, what you need to remember from the MCQ point of view regarding patch test is that remember that patch test is used for diagnosis of contact dermatitis. Okay, it is not used for the diagnosis of atopic dermatitis. It is not used for the diagnosis of any other eczema. It is used for the contact dermatitis. In a patch test, what you do is that you place the allergens on the fins chambers. They are aluminium shaped discs which are mounted on a micropore tape. So on those fins chambers, you place your allergens and you stick that entire tape onto the back of the patient. You send the patient home, tell the patient home to come back after 48 hours. After 48 hours, when the patient comes back, you remove the tape and you look for any evidence of redness, look for any evidence of edema, vesiculation, and that is how you will grade the positivity of the patch test. So there are 3 readings that you need to take. One is 48 hours after applying the patch. The second reading is 96 hours after applying the patch, and the other is 7 days after applying the patch. Okay, so remember the MCQ is that which is the most appropriate time or the best time to read the patch test. It is after 96 hours of applying the patch, that is on day 4. Then the next question that I am asked in the last 2 minutes, I will try to answer. What is the difference between scleroderma and scleridema? Scleridema is basically something that you see with long-standing diabetes. It is also called as scleridema adultorum of Buschke, while scleroderma is a connective tissue disorder. The difference clinically, how you can differentiate between the two, is that in scleroderma you are going to see sclerodactyly. There will be positive Reynolds phenomenon. So you will be unable to pinch the skin over the dorsum of the hand, over the dorsa of the fingers. And when you see the tips of the fingers, you will see the presence of stellate scars. You will also look at the nail fold and you will be able to see the nail fold telangiectasia. While in scleridema, you will not see any sclerodactyly. You will see that there is difficulty in pinching the skin on the trunk, but the acral areas will be spared. So that is how you differentiate between the two. Reynolds phenomenon is something that you expect in scleroderma. You don't expect that in scleridema. Last 1 minute. Best reading at 96 hours. Yes, you are right, Shubham. Best reading of a patch test is at 96 hours. So any more questions or we call it a day? So before I leave, please do subscribe to Unacademy. It is very, the rates at what they are giving you is superb, amazing. I don't think you will get these rates now. So please, before April 30th, do subscribe to Unacademy with a 25% off. And please do use the code MENTOR, MENTOR is the code that you use to get access to that particular discount. Okay, so thank you very much. It was an amazing session. I loved it completely. You people were very, interactive. I have enjoyed myself and I hope you did as well. So with that, I take your leave. Thank you very much and have a great day. See you soon. Bye.